can you look at this particular diagram? Everyone can appreciate this diagram. What is this? This is the normal glomerulus that we can appreciate in this diagram. And if you can see, this is the diseased glomerulus in case of post-streptococcal glomerulonephritis. Now what we can see over here, this particular glomerulus, they have been enlarged. Yes, you will agree with me. And can you see that there is an increased cellularity? So if you compare this glomerulus along with this glomerulus, you will be able to appreciate. So there is a hypercellularity of the glomerulus because of infiltration by the infiltration of the leukocytes and proliferation of the intrinsic glomerular cells, that is the mesangial cells and the endothelial cells. This is the classical morphological feature. Now you tell me, what is this particular structure? What is this particular structure that I have highlighted? Yes, this is the glomerulus that has been pushed. And can you see this structure? What is this structure? Yes, what is this structure? These are the characteristic crescents that we see. These are the characteristic crescents that we see. Very, very important point. This is the Psgn under which we can see the crescentic glomerulonephritis. There we can see the compressed, this is the compressed glomerulus over here, and we can see the crescent shaped mass which is formed by the proliferation of the parietal epithelial cells along with the infiltration of the leukocytes. Under electron microscopy, be any variety, whether it be type 1, 2 or 3, you will see characteristically that there is a wrinkling. The glomerular membrane has been wrinkled, and at places you will see that they are deficient. Okay, there is no. So there is a focal disruptions of the glomerular basement membrane which is seen in case of crescentic glomerulonephritis. So today's topic of discussion is glomerulopathies part 1. Okay, we are going to discuss the individual glomerular disease. First, very important, we are going to study some disorders, okay, which are characterizing nephritic syndrome. So let us see. So which are the glomerular disease which are presenting with a nephritic syndrome? So all the glomerular disease which is presenting with nephritic syndrome are characterized classically by inflammation in the glomerulus. So the main clinical features of nephritic syndrome includes hematuria, the presence of RBCs in the urine as well as red cell cast in the urine, proteinuria, that is usually in the subnephrotic range with or without edema, azotemia, as well as hypertension. So these are the very important clinical features of a patient presenting with a nephritic syndrome. Now, nephritic syndrome is a typical clinical manifestation of most proliferative variety of glomerulonephritis. So what are the glomerulopathies which are basically presenting as a nephritic syndrome? Very important. Psgn, that is the post-streptococcal or post-infectious glomerulonephritis, crescentic glomerulonephritis, and proliferative lupus glomerulonephritis. Now remember, the lesions that cause the nephritic syndrome, they have in common the proliferation of the cells within the glomerulus, often accompanied by inflammatory leukocytic infiltration. Now the inflammation reaction severely will injure the capillary walls, permitting the blood to pass into urine and inducing hemodynamic changes that leads to reduction in the GFR. So very important exam question, that why in nephrotic syndrome you are having hematuria. So you will have to say that in nephritic syndrome we have this because the common denominator over here is proliferation of the cells with inflammatory leukocyte infiltration, and this inflammatory reaction is going to injure the capillary walls, permitting the blood to pass into the urine, which is the cause of hematuria. So this is a very important viva question in your board exams. Okay. Also, the second important feature over here is in case of nephritic syndrome, there is a classical reduction in the glomerular filtration rate. Very important. And the reduced GFR is manifested clinically by oliguria, fluid retention, and azotemia. Now, hypertension probably is a result of both the fluid retention as well as renin release from the ischemic kidney. So, if you are asked what is the cause of hypertension in case of nephritic syndrome, so you have to say it is because of fluid retention and because of renin release from the ischemic kidneys. Now, we are first going to discuss under the nephritic syndrome the acute proliferative, post-infectious and infection-associated glomerulonephritis. So let us discuss this. So as this name implies, it is a cluster of disease characterized histologically by diffuse proliferation of the glomerular cells, associated with influx of leukocytes typically caused by immune complex. We have already read about the pathology and we have know this, okay, that what is happening we already know. Okay, so the inciting antigen also, it can be either exogenous or endogenous. This we have already read. Okay, and the prototype exogenous antigen induced disease is the post-infectious glomerulonephritis. Wherein the example of an endogenous antigen induced glomerulonephritis will become nephritis of SLE. So nephritis because of an exogenous agent can be post-infectious glomerulonephritis, and because of an endogenous agent can be exemplified by nephritis of SLE. Now the most common infection which is causing this nephritic syndrome is post-streptococcal glomerulonephritis. Okay, so it usually appears 1 to 4 weeks after a streptococcal infection of either the throat, that is the pharynx, or the skin. So skin infections are commonly associated with overcrowding and poor hygiene. So there will be a history of an episode of either a sore throat or history of an episode of skin infection will be there. 1 to 4 weeks after the streptococcal infection, you will see that the patient has developed acute post-streptococcal glomerulonephritis. So it is very frequent. If you see, the post-streptococcal glomerulonephritis occurs most frequently in children between 6 to 10 years of age. Okay, children between 6 to 10 years of age, this is going to classically happen. But children and adults of any age can be affected as well. Now coming to the pathogenesis of post-streptococcal glomerulonephritis, it is caused by the immune complex which is containing the streptococcal antigens and the specific antibody. So over here there is an antigen, that is the streptococcal, and this is an exogenous antigen. So once it enters the body, specific antibodies will come. Can anyone tell me the name of this antibody against the streptococci? What we call it as? ASO. We also do this test in the laboratory. Now not all strains of streptococci is going to cause this post-streptococcal glomerulonephritis. No, only certain groups of group A beta hemolytic streptococcus only are nephritogenec. More than 90% of the cases are because of the type 12, 4 and 1 of what? Type 12, 4, 1 of group A beta hemolytic streptococci. Okay, and this grouping that we do, the typing, that is type 12, 4 and 1, it is basically done on the basis of the M protein present in the bacterial cell wall. Now very importantly, elevated titers of antibodies against one or more streptococcal antigens are present in great majority. For example, ASO will be raised. Okay, now very important, because over here the antigen antibody complex, immune complex is formed that is going to activate the complement system. So in most of the immune complex based disorders, you will see a decrease in the level of the complement protein. Why? Because of the consumption of the complement proteins. And also in most of the immune based disorders except the anti-glomerular basement membrane glomerulonephritis, all of them under the immunofluorescence will show granular immune deposits in the glomerulus. Okay. Now the streptococcal antigenic component which is responsible for the immune reaction has been identified as an exotoxin B, that is the streptococcal pyogenic exotoxin B, called as SPEB. It is the principal antigen. If the MCQ is that, it is the principal antigen. Now very important point you have to understand that this protein can also directly activate the complement. Okay, this protein can directly activate the complement and is commonly secreted by nephritogenic strain, that is the 12, 4 and 1 that we have already read, and they will cause hump-like deposits characteristic of this disease. Okay, so this hump-like deposits, very importantly, these are nothing but these sub-epithelial deposits, the hump-like deposit. Now very important, early in the course of the disease, in the course of the disease, the inciting agents are planted exogenously from the circulation in the subendothelial location. So the initial immune complex that you will see in the subendothelial location in the initial cases. Okay, very important. But subsequently, through unknown mechanism, these antigen antibody complex that is formed, they will migrate across the GBM towards the subepithelial thighs. So ultimately, in later on, there will be classical subepithelial deposition. So in Psgn or acute post-streptococcal glomerulonephritis, initially the deposits will be in the subendothelial region. Later on, it will be in the subepithelial region. Okay, very, very important. Now, a similar type of a form of glomerulonephritis can occur sporadically in association with other infections also. So not only the streptococcus, so many other, like in bacterial you can have staphylococcal, pneumococcal, etc. Some viral infections like hepatitis B, C can also induce such kind of glomerulonephritis. Parasitic infections like malaria, toxoplasmosis might also induce this kind of this. Okay, but the most common is the group B beta hemolytic streptococci. The type will be 12, 4 and 1 nephritogenic strain. Now we have already seen before that basically under the immunofluorescence, okay, they will have a granular deposits, and under electron microscopy in the later stage, which is the final stage, you will have the subepithelial humps, which is characteristics of this immune complex disease. Okay. Any doubts anyone is having? Now, if you look at the morphology, if you look at the basic morphology, the classic histological picture that you will see over here is one of enlarged hypercellular glomerulus. Now, as I told you, whenever there is any kind of inflammation or any type of nephritic syndrome, if you see, so you will have an enlarged glomerulus which will be hypercellular. Now, why is the hypercellularity? Because of increased inflammation, infiltration of the inflammatory cell, because of proliferation of the mesangial and endothelial cell, and in severe cases there might be crescent formation characterized by Rpgn, which we will read later on. Now, the proliferation and the leukocyte infiltration is typically global and it is diffuse. That means the affection, for example, there are 1, 2, 3, 4 glomerulus. So all the 4 glomerulus will be involved, and within each glomerulus you will see that the entire glomerulus is involved. That is, there is a global involvement. Okay. By immunofluorescence, as I told you, there is a granular deposits of IgG and C3, and sometimes IgM might also be seen in the mesangium. Now, the characteristic electron microscopic finding is electron dense deposits on the epithelial. So subepithelial deposits you will see, that is called as subepithelial humps. Okay, and subendothelial deposits, even if you see, it is just indicating an early part of the disease process. Okay, an early part of the disease process. So can you look at this particular diagram? Everyone can appreciate this diagram. What is this? This is the normal glomerulus that we can appreciate in this diagram. And if you can see, this is the diseased glomerulus in case of post-streptococcal glomerulonephritis. Now, what we can see over here, this particular glomerulus, they have been enlarged. Yes, you will agree with me. And can you see that there is an increased cellularity? So if you compare this glomerulus along with this glomerulus, you will be able to appreciate. So there is a hypercellularity of the glomerulus because of infiltration by the infiltration of the leukocytes and the proliferation of the intrinsic glomerular cells, that is the mesangial cells and the endothelial cell. Light microscopic feature. If you can see over here, there is a deposition of subepithelial hump. Okay, they get deposited. Okay, subepithelial humps can be seen deposited by the electron microscopy, and if you see by immunofluorescence, if you see the kind of deposits, okay, so classically these deposits are like granular dot dot, they are not in a straight line. So these are the classical granular deposits, which is basically comprising of C3 complement and IgG. Okay, and these are corresponding to the subepithelial humps that we see in post-streptococcal glomerulonephritis. Now, very important, if you look at the clinical features, okay, in a typical case, a young child will abruptly develop malaise, fever, nausea, oliguria and hematuria. He will have a smoky urine or cola colored urine, as we can say, and this will happen 1 to 2 weeks after recovery from a sore throat. So a history of sore throat or a skin infection will be there. Now, the patient's urine examination will show dysmorphic RBCs, very important point, or presence of red cell cast in the urine. Now, though proteinuria is there, it will be subnephrotic, mild proteinuria, usually less than 1 gram per day. Okay, periorbital edema and mild to moderate hypertension. Now, in adults, the disease is more atypical, such as there will be sudden appearance of hypertension or edema in adults. Frequently, they are associated with elevation of blood urea nitrogen. Now, laboratory findings, what did I tell you? There will be specific antibody against streptococci. So, ASO titer is raised and there's a decreased amount of serum complement 3. That is the complements, because they are exhausted. So, their levels decrease in the serum. Now, more than 95% of the affected children, eventually they will recover the renal function with conservative therapy, which is aimed at maintaining sodium and water balance. And a small minority of children, only less than 1%, will not improve and they will become severely oliguric and develop a rapidly progressive form of glomerulonephritis. Okay, is this very clear? Okay. Now, some of the remaining patients, okay, if you see, they may undergo slow progression to chronic glomerulonephritis with or without recurrence of an active nephritic picture. Now remember, the prolonged and persistent heavy proteinuria and abnormal GFI will mark patients with an unfavorable prognosis. Now if you look, in case of children, the prognosis is far better, but in case of adult, the disease is far less benign in nature, and the overall prognosis in epidemics is good in about 60% of sporadic patients only. Okay, remember, just remember that in only about 60% of the sporadic cases will the patient recover promptly in case of adults, whereas in the remainder cases the disease is going to persist. There will be persistent proteinuria, hematuria, hypertension, and some of them might also go towards chronic glomerulonephritis or even rapidly progressive glomerulonephritis. Okay. The next form of nephritic syndrome that we will see, which is very, very important, is basically called as the CRESENTIC or rapidly progressive form of glomerulonephritis. Okay. So Rpgn, just try to understand, it is not a form of a disease, it is not a name of a disease, rather it is a descriptive term for any severe form of glomerulonephritis. Okay. So Rpgn, it is a clinical syndrome associated with a severe glomerular injury, but it does not denote any specific etiology. It is characterized by a very rapid and progressive loss of renal function associated with severe oliguria and signs of nephritic syndrome. If it is untreated, the death from renal failure may occur within few weeks to months. Now, the most common histologic picture over here is the presence of crescents in most of the glomerulus, hence the name, that is crescentic glomerulonephritis. So, if this is the glomerulus and this is the capillary network, okay, and this is the space, this is the urinary space. So, over here there will be proliferation of the parietal epithelial cells and they will start to form what is called as a crescent. So, the name is the crescentic glomerulonephritis. They are produced predominantly by the proliferation of the epithelial cells which are lining the Bowman's capsule. So, you tell me which epithelial cell is lining the Bowman's capsule? Yes, this is the parietal variety, which is basically lining. So, it is by the proliferation of more specifically the parietal epithelial cells, and not only that, they are also formed because of the infiltration of the monocytes and the macrophage. So, the crescents are produced by the proliferation of the parietal epithelial cells lining the Bowman capsule along with the infiltration of the monocytes and the macrophages. Now, we will understand the pathogenesis of crescentic glomerulonephritis. Okay. Now, remember, crescentic glomerulonephritis might be a manifestation of a large number of disease. Some of them might be primary, they are limited to the kidney, whereas some of them might be systemic. Okay, so secondary to systemic disorder it will occur. Now, although no single mechanism can explain all the cases, there is little doubt that in most cases the glomerular injury is immunologically mediated. So, in all the cases, okay, the basic pathogenesis is because of immune mediated complex deposition. Just remember, it is immunologically mediated in most cases, but remember, not all the cases. We will see that Rpgn is type 1, 2 and 3, and the type 3 variety is the pauci-immune variety. So, a practical classification is going to divide the crescentic glomerulonephritis in 3 important groups based on the immunological findings. Okay, there are 3 important groups over here. Okay. So, the first group over here, that is the type 1, if you see, it is the anti-glomerular basement membrane antibody mediated disease, that is the anti-GBM antibody mediated disease, जहाँ पर we had seen that there was a linear variety of deposition of immunoglobulin in the immunofluorescence study, and in many cases you can see C3 deposition also. So very, very important. We have also seen that in those individuals who have anti-GBM antibodies, so they are not only attacking the basement membrane of the kidney, but they will cross react with the pulmonary alveolar basement membrane, leading to pulmonary hemorrhage, and this condition associated with renal failure is called as Goodpasture syndrome. So over here what you have to remove this bad antibody from the circulation. So you have to carry plasmapheresis in such individuals. Now the antigen which is common to both the alveolar basement membrane and the glomerular basement membrane is a peptide within the non-collagenous portion of alpha 3 chain of type 4 collagen, which we have already discussed in the pathology. Okay, so very, very important. What is the cause? Why this kind of antibody is triggered? So there is no clear answer, but it is hypothesized that exposure to certain viruses or hydrocarbon solvent might be a cause, and there is an association with HLA-DRB1 in such individuals. So this is the first variety of the Rpgn, that is the anti-GBM antibody mediated disease. The second important variety is the disease which is caused by immune complex deposition, okay, with granular deposits of the antibodies and complement by immunofluorescence. Over here in the first variety, the immunofluorescence has showed the linear kind of deposit, but in the second variety we can see there's an immune complex deposition, and over here classically we have the granular variety. Okay, we have the granular variety. Now it might be a complication of any type of complex nephritis. For example, right now we read about the post-infectious glomerulonephritis. In some individuals, this might become severe and it might give rise to CRESENTIC variety. Lupus nephritis, which is the most common endogenous antigen causing this nephritic syndrome, so they might also become severe and cause Rpgn. IgA nephropathy can also cause, henoch-Schönlein purpura can also lead. So different kinds of glomerulopathies in their severe form, they might give rise to your Rpgn, and those types are basically coming under the type 2 Rpgn. The third variety, which is very, very important, and there is a lot of update over here, is the Psgn variety of CRESENTIC glomerulonephritis. Over here, classically, if you see, no anti-glomerular basement membrane antibodies were found, neither any immune complex was detected by immunofluorescence and lateral microscopy. So neither was this there, neither was this there, yet the morphology was that of Rpgn. So they formed the third group, that is called as the Psgn. Psg means that when there is paucity of something, when that something is present in less quantity, we call it as Psg. So over here there is no sign symptom of any immune complex or any antibody. That is why we are calling it as Psg. Now most of this patient, okay, this type of Rpgn, instead they have one antibody called as ANCA, that is anti-neutrophil cytoplasmic antibody, and these are of two main types. One is called as the C-ANCA, one is called as the P-ANCA, depending on their staining pattern. So C-ANCA is called as the cytoplasmic ANCA, or P-ANCA is called as the perinuclear staining ANCA. Now this type, that is the third type, we are only talking about the Psgn variety over here. So we are talking about the Psgn variety. So this type of Rpgn, it may be a component of systemic vasculitis, such as it might be associated with a condition called as granulomatosis with polyangiitis. Formerly this was also called as vaginous granulomatosis or microscopic polyangiitis. So it might be associated with granulomatosis with polyangiitis, or it might be associated with microscopic polyangiitis. So the thing is, you should understand there is a history of vasculitis in such cases. Okay. Now in many cases the Psgn CRESENTIC glomerulonephritis is limited to the kidneys. So in many conditions they are systemic, but in many conditions they are primarily located just in the kidneys, and hence they are idiopathic. The cause is not known. Now more than 90% of such idiopathic case, that means where there is no associated vasculitis, okay, they will demonstrate what is called as C-ANCA. Now remember, C-ANCA is a previous term. Now the C-ANCA is called as PR3-ANCA. Why PR3? Because these antibodies are specific for the neutrophil granule proteinase 3. Okay, so they are called as PR3-ANCA. Or these idiopathic case, they will have what is called as the P-ANCA. Now this P ANCA is also called as MPO ANCA. MPO stands for myeloperoxidase because these antibodies have very high reactivity for neutrophil myeloperoxidase in the serum. So what you have to understand that post-immune Rpgn, they can occur either in the background of a systemic disease like a vasculitis, or it can occur as a solely present locally in the kidneys only. They are idiopathic. The idiopathic variety, 90% of the idiopathic variety, they are containing C ANCA or P ANCA. Now C ANCA is called as PR3 ANCA, or P ANCA, they are now called MPO ANCA. Okay, very clear. Now the presence of circulating ANCA in both idiopathic and in cases of crescentic that occur secondary to some kind of vasculitis. Okay, secondary to some kind of vasculitis, and similar pathological features in both settings have led to an idea that these disorders are pathogenetically related to each other. Okay, they are pathogenetically related. Now remember, according to this concept, remember all the crescentic glomerulonephritis of the post-immune type, they are manifestation of some kind of small vessel vasculitis or polyangiitis which is limited to the glomerulus and perhaps in the peritubular capillaries in idiopathic cases. So what they are trying to say that in the systemic variety, so they are associated with systemic vasculitis, but in the variety which is limited to the kidneys, that is the idiopathic variety, also there is vasculitis, but which is limited to the glomerulus. So in any variety they are associated with vasculitis only. So the very important highly sensitive diagnostic marker of the post-immune variety is your ANCAs. Okay, very important. So just to summarize over here, if you see 1/5 of the patients with Rpgn, they have anti-GBM antibody mediated glomerulonephritis, that is the type 1 without lung involvement. Another 1/4 they have immune complex mediated crescentic glomerulonephritis, that is the type 2, and the remainder they are having post-immune variety. So 1/5, 1/4 and the remainder or the major variety, major form, they are having post-immune. Now coming to the morphology, if you look at grossly, if you look at the kidneys grossly from outside, they are enlarged and they are quite pale, often containing petechial hemorrhage on their surface. So if you see dot petechial hemorrhage will be there. Depending on the underlying cause, the glomeruli often shows focal and segmental necrosis. Okay, and they will show diffuse or local endothelial proliferation as well as mesangial proliferation. Okay, now very important thing, that crescents are there which is formed, that we have already known. The crescents are classically formed by proliferation of the parietal cells or parietal epithelial cells, along with that by the infiltration of monocytes, macrophages and the inflammatory cells. Okay, now the crescents might enlarge and they might obliterate the urinary space and they might start to compress the glomerular tuft as well. Now very important thing, in between the crescents you will see the deposition of fibrin. Okay, so it is basically, basically proving that there is some role of the coagulation system also. By immunofluorescence, as I told you, in immune complex of type 2 variety, they will have granular immune deposits. Okay, basically in Goodpasture syndrome or patients with anti-GBM disease, they will have linear variety, and in post-immune variety, as the name suggests, it is post-immune, so you will not see any deposition under electron microscopy or by immunofluorescence. Electron microscopy, okay, discloses deposits in cases where there is immune complex deposition. Okay, very important. Now in time, most of the crescents, they will undergo organization. There will be segmental necrosis, therefore there will be scarring also over there. Very important. Okay. So these are the conditions and these are the 3 types that we have discussed. The type 1, 2 and 3. These examples I have already discussed in details. You please go through this example. Okay, already we have discussed this classification. Okay. So this is the classical morphological feature. Now you tell me, what is this particular structure? What is this particular structure that I have highlighted? Yes, this is the glomerulus that has been pushed. And can you see this structure? What is this structure? Yes, what is this structure? These are the characteristic crescents that we see. These are the characteristic crescents that we see. Very important point. This is the pastine under which we can see the crescentic glomerulonephritis. There we can see the compressed, this is the compressed glomerulus over here, and we can see the crescent shaped mass which is formed by the proliferation of the parietal epithelial cells along with the infiltration of the leukocytes. Under electron microscopy, be any variety, whether it be type 1, 2 or 3, you will see characteristically that there is a wrinkling, the glomerular membrane has been wrinkled, and at places you will see that they are deficient. Okay, there is no, so there is a focal disruptions of the glomerular basement membrane which is seen in case of crescentic glomerular nephritis. Looking at the clinical features, the renal manifestations of all forms of crescentic glomerulonephritis including hematuria include hematuria. So as we have seen any kind of nephritic syndrome, hematuria with RBC cast in urine, dysmorphic RBC, proteinuria will be subnephrotic or mild proteinuria, there will be hypertension with periorbital edema. In Goodpasture syndrome, because there will be cross reaction with the alveolar basement membrane, so there will be recurrent hemoptysis or even there will be life-threatening pulmonary hemorrhage. Now, when you do the serum or lab diagnosis, in case of type 1, you will demonstrate the anti-GBM antibodies. In case of any immune complex disease, you will see the anti-nuclear antibodies, and ANCAs are seen in type 3 variety. Okay, very important things. Okay, so this is all about with regards to your nephritic syndrome. In the next class, we will start the nephrotic syndrome and the diseases which are associated with the nephrotic syndrome.